Hello guys, welcome back once again to Pathology by Ranjit YouTube channel. So here I am going to discuss about a simple paper which was asked in RGHS exam. That's the pathology paper. I think it's the first part which was asked in December 2024. So what I'm going to do is I'm going to give you a series of videos, hopefully 3 videos a week, and let's see if it's possible to do more. And I'll be categorizing them under Karnataka, Tamil Nadu, Delhi and all other university exams. Hopefully before your final year, your exam comes up, the university exam, we'll have a good amount of resources. Whenever you want, you can quickly go through this and you can make wonderful notes out of it or just use it for quick revision, right? If you're first time here, click on the subscribe button and let's learn more pathology and medicine together. Let's jump right away to the question. So what I'll be doing in every question paper videos, I'll be decoding the LAQs, which is primarily very important for us to know what's the right answer. And we'll quickly go through 5-mark questions and 3-mark questions. If at all, if there's any difficult questions, let's talk about it. Otherwise, it's most straightforward thing. Like here, it's about Turner syndrome, which I'm sure you must have read already in the PW app, and you can definitely go and have a look at that, right? And obviously, we'll be solving all the 10 MCQs so that we can go with a handy number of questions in all the university exams. That is enough for you to crack all the 10 right MCQs in every paper, right? Let's dive in, right? So this first question, I hope you can see that it's a simple and a straightforward one. If you look at it, it's a 25-year-old male with complaints of bee sting on the face. That's an important history here. With severe pain, swelling within 10 minutes. Please know the time. Time duration is very important. Brought to the emergency room in confused state with difficulty in breathing, right? It's very straightforward and clear here. See, you have a classical patient with a bee sting and immediately there's kind of breathing difficulty and a confused state. Confused state is due to the hypoxia because not able to breathe, and this is a classical case of anaphylaxis. I want you to write anaphylaxis. I don't want you to write type 1 hypersensitivity or allergy because this is not a type 1 hypersensitivity allergy. This is purely anaphylaxis. It's a classical case of an anaphylactic shock. To be precise, right? Anaphylaxis or an anaphylactic shock should be good enough, right? So what do you write here? Answer is here. That's anaphylactic reaction. The details about the pathogenesis, morphology and evolution of this reaction. So here, what I will be discussing primarily in this with respect to anaphylaxis, like what you read in type 1 hypersensitivity, remove the initial sensitization phase. So in anaphylaxis, the only difference between type 1 hypersensitivity and anaphylaxis, there is no sensitization here. Even the first stimulus is going to give a very rampant response. And to end with anaphylaxis, the evolution, there's going to be intense vasospasm and there's going to be lots of fluid accumulation in the laryngeal pathway, which causes edema of the larynx, which reduces the air space, and that causes the confused state and anaphylaxis, right? That's how the progression of the second part of the question should go. But the answer here is a pure anaphylactic shock, right? Perfect. Let's go to the second question. Let's move this up. Let's read the question. I hope you guys also will be reading along with me. A 2-year-old female, age is important always, moderate pallor and jaundice. Clinical history of multiple blood transfusions. See, this is very important. I'll tell you why very soon, right? Peripheral smear shows microcytic hypochromic anemia. That's all. So now here, microcytic hypochromic anemia, I've always told to keep IDA as the first diagnosis. But here, I want to keep IDA later. Please remember, even in a 6-month or an 8-month-old kid, the first diagnosis for a microcytic hypochromic anemia is iron deficiency anemia, and that's all. But IDA is not going to cause an anemia and a jaundice and a severe enough anemia to cause multiple blood transfusion. So now, taking all into perspective, I have a history of jaundice, I have anemia. Though it said that it's moderate pallor, I would say that the moderateness is due to the blood transfusion. They're given a treatment here, that's why it's moderate. Otherwise, would have been definitely severe pallor. And it's a 2-year-old and multiple transfusions, all points down to a severe inherited hemolytic anemia that most likely will be Thal major. I want you to write just Thal major. If you write beta Thal major, also is good enough for me. But thalassemia major, it should not be minor, it should not be just thalassemia. You have to be very strong in saying it's Thal major because of the history, because of the severity, because of the age of presentation. I would think in terms of thalassemia major, right? And pathogenesis, I know you can easily write the pathogenesis. Put that all this lack of beta chain, clumping of alpha chain, which starts in the bone marrow, destroys everything, causes microcytic hypochromic anemia. You'll have in response to that marrow hyperplasia that causes the chipmunk faces and everything. And because of marrow is not able to do it, my spleen tries to compensate. You have extra medullary hematopoiesis. That's why you have a splenomegaly in this patient as well, right? And jaundice is because primarily due to hemolysis, right? And relevant investigations needed to establish the diagnosis. I want you to write both these things, if possible, and electrophoresis. See, when you say investigation of choice, this will be the investigation of choice. But relevant investigation has to start from history, family history, the presentation, the microscopic examination, the complete blood count, target cells, everything. But end with this, because this is what is going to tell me the clear-cut answer. Yes, this is thalassemia major or minor or whatever it is, right? That's about this question. This is a clear-cut, simple case of thal major, right? Perfect. Those are the two things I want you to remember here in the long answer. Like I said, short essays are something which is not very difficult. Turner syndrome, a straightforward thing, I'm sure you'll be able to write. Just to give a brief gist of it. Turner's, it's a monosomy, 45X. You can have mosaics. We have the mnemonic called as clowns, right? I'm sure you remember that. Cardiac defects, cleft problems, and L for a low hairline, low thyroid, O for an ovarian streak, W for a webbed neck. That's also a possibility, right? Even for C, you can have coarctation of aorta as well, right? N for the nipples being widely spaced because of the shield-like chest. S for the short stature, the commonest finding, and the short fourth metacarpal, which is a classical finding, right? You know this. So you have a baby, then obviously when you ask a syndrome, also include the diagnostic points. You can diagnose them easily with karyotyping if required fish. That's all for Turner's, right? Next, difference between Hodgkin's, non-Hodgkin's. The beautiful table in Robbins. We have read this multiple times. Go and have a look at the table. And please, it's a 5-mark question. Don't stick just to the table. Write a preface of what is Hodgkin's lymphoma, what is non-Hodgkin's lymphoma, the different types, and then put into the table of which will involve the Valdes link more, which will involve the mesenteric lymph nodes more, and the contiguous, non-contiguous spread, microscopy, RS cell with background inflammation, and there is different types of that, and also immunohistochemical profile. Make sure you do it better, right? I'll definitely give all the explanation also in the form of a PDF. Follow me on Instagram. I'll share everyone to you the PDF here, right? Okay, perfect. Next one. Leukemia reaction, we know that. Leukemia reaction is a leukemia-like reaction which happens in a very severe inflammation like sepsis. So when you have sepsis, you have all the premature precursor cells going into the periphery. Obviously, that gives a leukemia-like reaction called leukemia reaction. The commonest differential diagnosis is CML. The difference is LAP, lab score. Leukocyte alkaline phosphatase will be elevated in leukemia and be almost zero or reduced in case of a CML, right? Next, discuss between the vascular events and inflammation. I'm sure you know this. It's not much difficult here. Septic meningitis, CSF changes. Septic meningitis is primarily bacterial and also tubercular can be put into it, right? Primarily bacterial meningitis. I'll give you a beautiful table of CSF meningitis, the changes involved in CSF meningitis, right from the gross, microscopy, cellularity, everything. Follow me on the Instagram page. Like I said, every video I upload here, there'll be a PDF there for you with the answer sheet, which you can easily follow and read, right? Next, paraneoplastic syndrome, you know the definition, we have read about it. Asking one example, we know multiple examples for that, right? Hemophilia A, a simple one. Microbial carcinogenesis, whatever you write, don't forget these two guys. Hepatitis HPV has to be there. You can add on HTLV, you can add on Kaposi sarcoma, but these two are must, which should be there in case of a microbial induced carcinogenesis, right? Perfect. Now let's go to short answers. Short answers, some universities do have short answers, some they don't have short answers. So here, RGHS has short answers, 3-mark answers, simple, metaplasia, we know, change from one epithelium to another, use the example of both Barrett's as well as respiratory mucosa so that you will get 3 marks, not just 2.5. Fate of thrombus, it can undergo an embolus, it can resolve, it can reorganize, right? There are lots of fates of thrombus, right? It can just be there, it can become an organized tissue, it can have cannulations. There are lots of fates of thrombus. We have discussed about them and do write about them, right? Apoptosis, plenty examples, you know. It's a physiological form of cell death where you have an exact mechanism. That's why we call it a programmed cell death. You have both physiological and pathological examples for apoptosis, right? Chemotaxis, chemical mediated movement, unidirectional movement due to the chemokines were being secreted, interleukins, complement proteins being secreted, which helps in the WBCs to go to the site of the infection so that they can engulf or destroy the organism, right? What's FNAC? FNAC is a fine needle aspiration cytology, which is an investigation method where I am going to use a very small needle, a minimally invasive thing, and take out the cells and going to look in the microscopy. The best use case is FNAC of thyroid, FNAC of lymph node. These are the best use cases where you do FNAC on day-to-day activity. Whatever terms are used, please use them. That should be more than enough for it. Romanowski stain. You might have read this in your first year also, or you might have read this in the practicals. Your Leishman, your Jimsa, all these are Romanowski stain. and I'll give you the PDF of what exactly Romanowski stain is, right? Bombay blood group, H group, where you have the lack of the Cialis-Lewis X, which actually is the one which holds on to the blood group A and blood group B, the sugar moiety. So when it's not that, I don't have the Cialis-Lewis X at all, so it's a H group. The difference between O is, O will have the Cialis-Lewis arm, here I won't have the Cialis-Lewis arm. This could be a part and parcel of a leukocyte adhesion deficiency, LAD as well, right? Vitamin C deficiency, GONS, and demonstration of stains of amyloid. Very, very simple ones, right? Perfect. Now, let's quickly go to the MCQs. Because you guys are more worried about the MCQs, right? 10 MCQs. It's my job and it's your pleasure. You have to solve every MCQ correctly in both the papers of pathology. I'll make sure you'll do that, right? So let's go through it quickly one by one. Anticoagulant choice for coagulation study for coagulation studies, right? Answer is trisodium citrate. Trisodium citrate, which comes in a light blue vacutainer, is the anticoagulant of choice for coagulation studies, which means the PT and APTT, right? Actin and myosin, which are the protein thing. Actin and myosin are actually microfilaments. Tubulin is a microtubule. Your cytokeratin, your vimentin, your GFAP, all of them are intermediate filaments, right? Which of the following cytokines are involved in tissue repair and fibrosis? In other words, which interleukin or which cytokine is helping in healing? That's all. Healing has to be only one guy, which is TGF beta. Remember, transforming growth factor. It's a dead tissue. I'm going to transform the entire dead tissue or a damaged tissue into normal live tissue, right? That's about that. Let's go to the next guy. Next three more. Again, very, very simple ones. Characteristic feature of LCH, Langerhans cell histiocytosis, has to be Berber granules. That's the classical one, Berber granules. It's simple one. You must have seen the tennis racket shape appearance in electron microscopy. Though we don't use them in routine diagnosis, that's the answer here. Sickle cell trait is protective of falciparum malaria. Because of the limited viability of the cell and also a little bit alteration, the falciparum malarial pigment will not be able to, falciparum malaria will not be able to survive inside the sickle cell, and also it will not be sticky enough to cause cerebral complications, fine. NK cell is an inhibitory receptor for class 1 MHC molecule. That's an inhibitory receptor. It's an innate immune response, but an inhibitory receptor has class 1 MHC molecules, fine. The next three. Okay, familial hypercholesterolemia is caused due to mutation. It's there in Robbins, though we don't read much about that in Robbins. You must have read that in your biochemistry in the big table what you must read. LDL receptor mutation is something which causes familial hypercholesterolemia. Immune hydrops is RH incompatibility. We must have read that, right? The mother being an RH negative person, the baby being RH positive, the antibody crosses the placenta and causes the hydrops fetalis. It's immune hydrops. Not immune hydrops. Alpha thalassemia can be a cause of non-immune hydrops, right? Just to read about that. Cause of chloroma. Chloroma is nothing but AML or acute myeloid leukemia in tissues. That's what is chloroma, right? That's all. Could be AML M4, M5 or even M2. The answer is going to be myeloblast. Whenever I see myeloblast, I say it's a chloroma. Could be erythroblast also, I'm not denying, but myeloblast will be better and an appropriate answer for chloroma, right? Okay. The last guy. The subtype of Hodgkin's lymphoma, which shows lacunar cells and collagen bands. We have read almost everything in a lecture, which has to be nodular sclerosis. Solving a second year paper is not difficult. It's easy if you have a structured approach, and that's what this series is going to help you. We'll have for almost every university exam. Let's upload one by one tiny video. Go through it and come to our Instagram page. I'll give you the solved paper of every chapter, every paper for the past 5 years, so that you have the comparison in your palm of your finger, and let's read through it in the best way possible, right? Thank you guys. See you soon. Till then, bye-bye from Dr. Anjal. Bye-bye.